everybody. Welcome to this episode of Transplant Talks. I'm Rachel Davis, psychiatrist, living liver donor, and mentor for the American Transplant Foundation, and I'm here with my co-host, Anastasia Henry, who is executive director of the American Transplant Foundation.
Hi, everyone.
And this month, we wanted to focus on mental health. So, I've talked some about my mental health experiences or experience with depression and OCD. And we wanted to find a transplant professional, but I actually wasn't able to find a transplant professional who was willing to speak openly about mental illness or psychiatric diagnoses. And so we are honored to have Dr. Jeff Druck with us. He is an emergency medicine professor at University of Utah. He was actually at University of Colorado for 19 years, and that's how I know Dr. Druck originally. When I was medical director of student mental health, he was working in student affairs. And what was your title in student affairs exactly?
I was one of the assistant deans for student affairs.
Okay, so we worked together pretty closely then. And I knew Dr. Druck had been open about his experience with depression because you posted on LinkedIn about it, which I really appreciated your openness and willingness to share. Dr. Druck is currently Vice Chair for Faculty Advancement, Transformation, and Wellbeing at the Department of Emergency Medicine at University of Utah. And we're very grateful to have you here. Welcome.
Well, thanks so much for having me. Please call me Jeff.
Okay, I will. Well, let's start out. Can you just tell us a little bit about how you got into emergency medicine and a little bit about your career? And
Sure. So when I was in medical school, emergency medicine wasn't very prevalent. I know that it's the kind of thing that it's everywhere now, but back then my school didn't have emergency medicine. I actually was certain I was going to be a pediatrician. I was absolutely certain. I loved kids. I had been a camp counselor. I had babysat a ton, and I was certain that's what I was going to do. And then I did my pediatrics rotation. And I realized I do love kids. I just really dislike their parents. And I thought this is not going to work for me. So one of I had become the CPR trainer for the school, and the two guys who had done it the year before me were two people that I was like, oh, so what are you guys going to do? And they said, oh, I'm going to go into emergency medicine. And I said, what's that? And one of the guys is now one of the vice chairs at Southwestern. Another one went to another program as a community emergency medicine doctor. And so I talked to them about it, and they said, "Oh, you should do some away rotations." I did a couple of away rotations, and like I said, our school didn't have emergency medicine, and one thing led to another, and that led to my career in emergency medicine. I will say I couldn't imagine doing anything else now. I'm sure that I probably could have if I had finished medical school and that wasn't an option, but it's the kind of thing that it always keeps me interested. It's the opportunity to see something new every day, and it's helping people when they're really having their worst possible day. And so honestly, it's been a great career. It's been something that I really, really enjoy and something that I really find a lot of personal fulfillment in.
well, and while you may not be a transplant professional or a transplant surgeon or a hepatologist or a nephrologist, I think there are a lot of parallels between emergency medicine and transplant medicine in that you're both dealing with pretty intense situations, life and death situations, and that there are some similarities. Would you agree?
Yeah, I would definitely agree. And it's tough for me to put myself in a transplant surgeon's position. But I did a surgery internship and spent 3 months on the transplant service there. So it was the kind of thing that I have a little bit of exposure from that perspective. I do think that there's a couple of elements that overlap, and I think that one of the worst and one of the hardest to deal with is the whole idea of a patient that you've cared for dying. And for a transplant surgeon, I think that's probably even worse because they have a opportunity to form a real relationship with that person. And I think that's the kind of thing that is a known hazard of the profession. And obviously, in emergency medicine, we see a number of patients that come in, and there's not a ton that we can do sometimes to save them, and they still end up dying. And that is really, really hard for a lot of people to deal with.
Yes. And I just want to add that my mom, she started her medical career as an emergency medicine doctor, and she loved it so much. It was really hard, physically and emotionally, but she loved it so much that many years later, my cousin also she was an emergency medicine doctor. So I'm familiar with some of the challenges of this particular profession.
So
Thanks.
you talked about one of the hard things being dealing with life and death and losing a patient. What are some of the things you enjoy most about emergency medicine?
So I still feel like you get the opportunity to make a difference in people's lives, and I think that's one of the things that sometimes gets undervalued is that I saw this one video of Corey Slovis, who's sort of a legend in emergency medicine at Vanderbilt, and he put this video together with some students where a student says, "Oh, Dr. Slovis, tell me what it's like to be in emergency medicine." And he walks out of the room and he goes, "And well, walk with me." And so they start walking along, and some guy's choking, and he pops behind the guy and he does a Heimlich maneuver, and the guy, he's like, "Thank you for saving my life." And they walk down the street and someone arrests, and he goes and shocks the guy, and the guy stands up and says, "Thank you so much." And then he goes and he goes up to the helipad and he goes, "Well, thanks so much for talking with me, and I'm going to go home now," and gets into the helicopter and flies away. And people think that that's what emergency medicine is like, especially after seeing The Pit, which is this TV show that sort of glamorizes emergency medicine and puts everything exciting into a single episode. Um, but then Dr. Slovis put in another section where he's talking to a homeless patient, and he says to him, "So, sir, what's the problem that brings you in?" And the guy's like, "Well, my stomach really hurts." And he goes, "Well, why do you think that is?" And the guy's like, "Well, I haven't eaten in 2 days." And that's the kind of thing that you can make an immediate difference in somebody's life and have a dramatic impact. I do think that one of the things about emergency medicine is that you can't necessarily expect that you're going to get the kudos that you sometimes get in other professions with medicine. You don't get the person that thanks you. One of my mentors says you got to get your loving at home because you're not going to get it at work, and I think that is really true. So you have to realize that, if you see someone that's intoxicated and, you talk to them about quitting drinking and things like that, that you may not have an effect on that individual element, that one time, but, that you don't know when it's going to happen, that one time that you say something is going to have an effect. And so I think that you have to just believe that you're making a difference. Now, that being said, there are some opportunities that you do get to save somebody's life. And those are obviously wonderful. Those are great.
So ends of both spectrums.
Yeah, yeah, I think that's really true.
Yeah. So you've shared on LinkedIn that you've had depression. Can you tell us a little bit about when you first realized you had depression and what that was like, how you came to realize that?
Sure. So it was now I guess probably 8 years ago, something like that, where essentially every day was a struggle to get up. I didn't feel like I wanted to continue living. I would say, it was. I can't even really describe it to anyone aside from saying that you just feel like you have no motivation to do anything, and you think that sometimes the world would be a better place with you not there. And it got pretty bad. I mean, I thought about killing myself numerous times. And honestly, I would say that my support network was very strong, and I had a lot of people that cared about me. And I got on medication, which I think is actually the thing that made the biggest difference for me in terms of my depression. And then secondarily, also got into therapy, which I think is also crucial. And I think those two elements together really saved my life because I don't think that I would be here if I didn't get treatment.
Was it
Jeff?
difficult for you to recognize what was going on and to reach out?
I think it was definitely hard to reach out. I think that there's still a huge stigma associated with mental health issues, and there shouldn't be. I think especially among the medical community, and there have been a couple things that have happened as a result of some high-profile cases. So, like the Lorna Breen Foundation is one group that has been working to try and destigmatize some components around mental health. One of the things that used to be required for all physicians in a number of states, in fact, in almost every state, was you had to report whether or not you had any mental health problems and whether you were taking any medication. I'm happy to say that there's a large number of states that no longer have that restriction. I know Utah is one of them. I don't know, Rachel. Do you know, is Colorado one?
Yes, and I'm very proud of that, actually. I worked with Dr. Steve Lowenstein and a couple of medical students who I am unfortunately blanking on their names, but we worked with the Colorado Medical Board to remove those questions back in 2018. And then we actually I think the House just passed legislation. I don't know that it's been through the Senate yet, of making it even less destigmatizing. So asking about current impairment, not in the past even. So yes, Colorado is one of those states. So.
That's wonderful. That's absolutely wonderful. And I think that that's the kind of thing that needs to happen across the board. One of the things that I think you and I have talked about is that just the fact that people put mental health in a separate category, and really it should just be health. Your psychiatric components of your health should be just as important as the physical components of your health.
Right. Well, and you saw me slip into that in the beginning. I started talking about mental health issues, and that's kind of a pet peeve of mine. It's like, why do we call it mental health issues, right? We talk about cardiac disease, we talk about rheumatological disease, but we talk about mental health, not brain disease, or even mental illness is a better term than mental health, but we tend to skirt around it. We don't want to use those terms because of the stigma associated. And so I'll probably slip into it again, but uh,
Yeah, I think it's the kind of thing that I think that's one of the reasons that I'm pretty open about it. I've actually talked to, when I was a student affairs dean, I talked to the medical students at the University of Colorado about it. I've spoken openly to the residents at the University of Utah about it. And I think that it's crucial that people are willing to talk about their problems because, if you look at the data, around 18% of the US adult population is on antidepressants. And so to think that, one in five is a pretty high number, and to think that you don't have people that are in your sphere of influence that are undergoing the exact same thing, I think is not very realistic.
I want to come back to that. But first, I want to ask you more about your experience of depression. I think that could be useful for physicians or really for anybody listening to really understand what it feels like to have depression and how you recognize that what was going on was not normal and something that ultimately you needed to reach out for help with. Could you say more about what that felt like?
Yeah, I think in emergency medicine we see a lot of people that come in suicidal, and so it's a harm to yourself, harm to others, psychosis. Those are the sorts of things that we're constantly looking for. And so I don't think that it's something that's completely foreign to me or that I had never, thought about from that perspective. But I think that the thing that was so hard for me to do was to realize that I wasn't just in my normal state and that it wasn't going to be something that I was just going to snap out of. And I think honestly, it was a pretty prolonged period of time. It was months before I finally was like, oh my gosh, I got to do something about this. And I will say the other component is that because you have no motivation to do anything, the extra effort that it takes to get in to see someone, the extra effort that it takes to get on medications is just this bar that seems so impossible for you to get to. And I think that's an additional element. And I had a lot of friends that were like, "Hey, you doing okay?" And I'd be like, "Yeah, I'm fine. Yeah, no problem." And I think that that's one of those sort of covering it up kind of things. And I remember being in my office and just weeping, just literally weeping about how horrible things were and how it would be better if I wasn't around. And when I realized, boy, if I had a student that was doing this, I would immediately be getting them help. Why am I not doing the same thing for myself? And that was really a wake-up call to me.
So how did you get help?
So I made an appointment with a therapist that a friend of mine recommended, and made an appointment with a psychiatrist that a friend of mine recommended, and got on medications relatively rapidly, and I saw a dramatic change. I mean, I know that the teaching is that it takes 3 weeks, 4 weeks for things to happen, and I don't know how much of it was psychosomatic for me, but I would say after 2 weeks, I started feeling dramatically better, and could definitely see like how destructive depression had been for me and how it had sort of inhibited a lot of relationships that I had had and inhibited my ability to do a lot of things that I thought were really important.
Well, and I can relate to that. I actually had depression and OCD since childhood, which wasn't treated and really not recognized until medical school when I just couldn't keep going. There was really no choice but to either I found myself thinking I have to not do this or something has to change. And I came from a background where there was a lot of stigma, super conservative religious upbringing where mental illness wasn't really a thing. And if it was a thing, it was something to be ashamed of. And so it was really like it really had to have no other option. And so I reached out, and I'd say my response to medication was dramatic as well. It took a few weeks, but I remember one day just driving and like all of a sudden things seemed brighter. And I thought, wow, I don't feel like I'm going to sink into the ground anymore. I feel like I can move forward a little bit. And then after that, medical school seemed easy. So, I mean, relatively speaking,
Yeah.
moving forward, like it never crossed my mind to stop medication. You know, some people, I think since I had depression since childhood, the change was so dramatic. I'm like, I never ever want to go back to that. I never looked back.
Yeah.
Anastasia, you.
Yeah.
Yeah.
Sorry, go ahead.
Yes, I just wanted to add that I hear you. I hear you so much when you say that just growing up in that environment, right? And I hear you because I like, oh, that are the religious constraints, and I'm thinking of cultural constraints. And I'm an immigrant, and in Eastern Europe, like being on antidepressants, it's to this day people be like, what's happening? And also there's the stigma that once you start antidepressant, then it's going to be so difficult to stop. So a lot of people hesitate. So can you just educate us a little bit more about that?
Sure. Well, like I said, I never want to stop. The difference for me was black and white, but I think that's not the case for everyone. I think sometimes when people don't have childhood depression and they have an episode of depression that comes on when they're an adult, they can take a medication for a period of time. We usually say at least 6 months, probably a year is better before trying to taper off. And then you don't ever want to stop it abruptly, but there are ways to taper off and to very gradually reduce your dose. And for some people that's possible. You know, sometimes depression is triggered by life circumstances and someone may be in a place in life where things are harder and they get depressed and then life gets better and their depression is better and they're able to taper off. But depression is also a very biological thing. And so it's not so much that someone becomes dependent on the medication per se, it's that they have an illness in their brain and that illness may or may not go away. And for many people, it's chronic and it doesn't go away. So it's not that the medications make you dependent on them, it's that you have an illness, just as if you had diabetes and you would continue to need metformin or insulin or something. It's not that your body gets used to it and you're stuck on it.
It's excellent clarification. I think it's so important that like we still need to educate ourselves. And are there any criteria when you know what, I'm at this point? Like obviously we heard Jeff's story, and Jeff was just like in such a dark place. What is the ideal situation? At what point do you know that, you know what, I should talk to my doctor about antidepressants?
I mean, there doesn't have to be an exact point, but I think some things that you can watch for is, and I guess I'll talk about maybe physicians first and then people in general. But I think in physicians, if you find that, you know, you're really resenting your work and you're barely making it through the day, and if tasks that you once were able to do easily or without too much effort now seem like you just can't get past it, or if you know the politics at work seems like a completely absorbing you and you're drowning, or if you've made mistakes at work and you can't move on from them, you're stuck on them, or if something bad has happened and you can't stop ruminating about it. You know, not wanting to go to work, not wanting to get out of bed, not being able to get out of bed, not being able to sleep, having thoughts of dying. And I could keep going, but I don't know, Jeff, what would you add to that list?
Yeah, I would agree wholeheartedly. I think, if you're cognizant and you're paying attention to how you're feeling about things, I would say that the things that sort of clued me in were those elements of, honestly, work was actually a great thing for me because I still felt like it was a purpose and I was like, I need to do this. And it was actually the thing that did get me up in the morning. Work and my kids, that was pretty much it. And I just didn't find any enjoyment in doing any of the things that I usually like to do. And meeting with friends and talking to people and doing other things, is something that I usually enjoy quite a bit, and I found no enjoyment in it at all. I mean, it was like life was blah.
And my question is, was there a particular event that you started feeling that way, or just accumulation of stress of being in this field? Like, what was that? What do you
Yeah,
think?
I wouldn't actually say that it was. I don't think it was related to work for me. I had some problems in my home life that were difficult, and that probably was an inciting event. But talking to a number of people, I think that depression is something that runs in my family, and something that a lot of folks in my family have already had problems with. And along the lines of what Rachel was saying, I couldn't imagine going back to how I felt. I mean, I would be driving down the road, and as I was driving down the freeway, I would think, boy, if I just move my wheel to the right a little bit, I could run directly into this embankment. And every single day was like that. Every single day was, oh my gosh, I would be better off not being here. I would be better off not existing. Everyone else would be better off without me. Why do I keep on doing this? And I never want to feel that way again. So I'm still on medication, and I couldn't imagine coming off of it, not because and it's possible that I wouldn't have those symptoms, but I don't even want to have that risk. So I'm not willing to stop the medications that I'm on currently.
Yeah, and I can totally relate to that. I remember as a child with OCD, I was afraid I was going to get cancer or some horrible illness. I had memorized all these symptom flow charts. But as an adult, or once I started in college and medical school, I started wishing I would get cancer because then there would be a way out. But then I felt guilty for wishing that, and I felt like there was something horribly wrong with me. And it was kind of the same. It was really wanting to be a doctor that kept me going. That was probably the only reason I had enough courage to reach out and get help, is because I really wanted to do that, and I didn't want anything to hold me back.
Yeah, I think that having that driving ambition and having that, like I said, for me, it's that I still was able to see that what I was doing for students was having an effect. And similarly, that I could see that, dealing with my kids and helping them also was something that was really important to me. And still having that fundamental element at the base of who I was really easy to keep me on track.
So I'm curious, have you had any repercussions of being open about depression?
That's a great question. I will tell you it's interesting. I interviewed for a few jobs and was have been fortunate to be offered a bunch of them, which is nice. One of the positions that I applied for was as the senior associate dean at a medical school, um, and I made it to the final two, which was nice. And again, I'm open even during my job interviews, and I had an interview that was with the entire faculty of the school where it was open to anybody to ask questions, and I talked about it there, and I had one person reach out to me and say, "Hey, I just want to let you know I thought that was super brave that you did that. I also think that it's going to sink your chances of getting a job here."
Wow. Wow.
And I understand that. I understand that it's not the kind of thing that people are willing to fess up to, and it's not the kind of thing that doesn't have that stigma attached. And honestly, I don't know if that job would have been right for me if that was the kind of thing that I needed to hide.
Right.
And so I think it's important from that perspective that you're in an environment that's going to be accepting of the fact that you do have a disease. And I don't think that there's anyone that would be like, oh, I'm not going to talk about my diabetes because I don't think that I'm going to get a job because of it. And I think that's actually really sad.
Right. Right.
It's heartbreaking, and it's also you saying, yes, I have a disease, but and I found, like, I'm managing my disease, right? Like, I'm very, very aware of it, and I am doing great given the circumstances, and yet that is not acceptable to some institutions. And earlier this year there was a really tragic loss of one of incredible hepatologist in this country, who took his life. And he was so well connected, and he got all the titles that you can think of, right? Like leadership positions within the transplant community. And when we lost him, everybody said, we had no idea. We had no idea. And to me, as a society, if things like this are happening and people just hiding it and deeper and deeper and deeper, right? And so like, how can we create that support and how can we normalize it? I'm very proud to say that at the American Transplant Foundation, we have health insurance policy for our employees that offer unlimited therapy. So that is one of the things that I'm very passionate about, because we talk about depression and burnout within medical community, and trust me, there's a lot of it in nonprofit community for nonprofit employees and leaders, and that has been really invaluable tool just to make sure that we have that support available.
I love that. I will say there have been a couple of studies that have been done in the medical literature that talk about how it is that you destigmatize some components of this. And they talk about mandatory visits so that everybody has to go see, a psychologist or a psychiatrist at least once when they get hired. And that way you know where the office is and you know what it's going to be like. And so it destigmatizes it at least a little bit. And I think those are the kinds of things that we need to do a better job of. And honestly, I do think that it's one of those things that primary care doctors should feel very comfortable talking about. Because, if 1 out of every 5 of your patients is experiencing something that's severe enough that you need to be on medication, you would assume that they'd be willing to talk about it. And I think that it's one of those things that does get glossed over because of the stigma.
Yeah, I think that's true. And I think in medicine, one of the things that a lot of people resort to is talking about burnout and wellness instead of talking about depression or mental illness. And while that can be useful, I also think it is driven by stigma sometimes. And so I'm curious, what are your thoughts about burnout versus depression? Are they the same? Are they different?
Yeah, I think that they're two different things. I think that depression is truly caused by an imbalance in your brain. And I think that the problems associated with depression are much more dramatic. I do understand that with burnout, that it's a loss of enjoyment in the things that you care about, and that there's sort of the three axes that you talk about with burnout. But I do think that, and I think that burnout can definitely trigger depression. Like you were talking about how there are different incidents that can happen that can make things worse for different people. And I think that can be definitely a huge component of it. But I think that they are two different entities as it exists. And I think that, not getting treated for depression would be a horrible, horrible thing for burnout, which is something that in my role as vice chair for well-being, I talk to a lot of people about. And we talk about what it is that you do enjoy. And for people that have burnout, usually there's other things that they enjoy. Whereas for people with depression, it seems like there's nothing that you enjoy. And so I think that's really the big difference. And, I was talking to one of my colleagues who was talking about how they were feeling burned out. And I said, well, how do you feel when you go fishing? And they're like, I love fishing. And I was like, well, that's the big difference there. And we need to talk about what we can do to change your life so that the elements that are associated with burnout are things that you aren't doing on a regular basis.
Right.
Rachel, I know you're mental health professional, uh, psychiatrist. I shouldn't say mental health professional, psychiatrist.
There's
But
no better.
yes, but for me, as a nonprofit professional, this was like one of the most brilliant things, like, as far as like, how do you define burnout? How do you know when it's a burnout versus depression? That was such an excellent and clear definition. So thank you so much, Jeff.
Sure, you bet. I don't know, Rachel, is that accurate from a psychiatry
Psychiatry.
standpoint? I just want to make sure. I don't want to say something wrong.
Yeah,
That's
no, I
good.
think that's entirely accurate. I think the enjoyment of other things is something that just isn't present in depression. Depression is pervasive across everything. I wanted to comment on one of the things you were mentioning, Anastasia, about how people often say when someone dies by suicide, we had no idea. And I think one of the things to know is that people often the last place where people suffer is at their job. And people are often able to really maintain high achievement and high accomplishment when they are really suffering. And sometimes it's even the fact that they're maintaining that high accomplishment and high achieving that drives the shame because they're thinking, I'm this person who's seen as this. If anybody really knew what was going on, I would not be okay. They would not be okay with me. And that shame then unfortunately sometimes leads to suicide.
What can we do, like, for medical professionals, like, even for this podcast, we emailed over 100 social workers all across America. And we said, who wants to come out and share your story? Because we know you can say we always burned out, right? It's just like this permanent state of being overwhelmed, stressed out, burned out. And guess how many people responded and said, yes, I want to come out and talk about it. How many? Nobody. So what can we do, like as a society, as a medical community, to make it more acceptable?
Well, I'm like Jeff. I talk openly about it. I don't hide that I have OCD. And is that awkward sometimes? Yes, because sometimes I wonder, are people thinking I'm doing something because I have OCD? Probably. And fortunately, I'm at a point in my career where I can tolerate that. I think it's harder for people earlier in their career sometimes to be open because there is judgment and there is stigma. So I think what people can do is, I guess I'll say, if anybody's listening to this and would also like to talk about their experience with depression or another mental illness, we would love to have you on this podcast. But I think the more we can talk openly about it and not be afraid to ask people about what they're experiencing, or if you have a friend or a colleague who seems like they're not doing okay, even just a little, asking them what's going on. And Jeff, you look like you were going to add something there.
No, I 100% agree. I think that talking openly is a key element. And I think that secondarily, it's that idea that everyone that's around you has struggles.
Mhm.
And I forget who it is. There's a great quote that's something along the lines of everyone is struggling every day, you just don't know about it. And I think that that's really true. I don't think that anyone lives a charmed life, no matter how much you think that somebody else's life is great. And it's probably just because you don't know the struggles that everybody has. And so I think that us being a little more accepting of each other and a little more kind to each other is really something that we should focus on going forward as a society. And I don't know how it is that we make that happen, but I think that if you do it in every single relationship that you have, that you'll do a much better job.
I think that it starts small. I used to be so ashamed to acknowledge that I'm a highly sensitive person. And there's certain things that like smells or sounds, right? Like they really affect me. And because I was like, well, I don't want to come across as this high maintenance person. But at the same time, if you do acknowledge and your team understands where you're coming from, maybe, you're a highly sensitive person, maybe you struggle with ADHD, neurodiversity, anxiety disorder. Like, I think it's empowering if you say, maybe I'm not a crazy micromanager. I just have anxiety disorder. So if I ask you several times, have this been done? Has this been done? That's where I'm coming from. So it's not that I don't trust you. I just have that in me. So I need like double check and triple check. So we all understand our differences. And instead of viewing them as something annoying or strange, like we embrace it.
I love that.
I'm curious, Jeff, you worked with students a lot, and obviously students are at the very beginning of their career. What have you noticed in students that has made it difficult for them to admit that they're struggling or have depression or even start to get help?
Yeah, I think that part of it is this normalization that everybody, this idea that no one else has your disease, and thinking, boy, I'm unique. I'm the only one that's like this. Why am I having so much trouble compared to everybody else? Everybody else is doing fine. Why can't I do fine also? So I think that's the first thing. I think the second thing is that again, the stigma is pretty robust. I think the third thing for students is that they feel like they have no time. And it's one of the things that I, I, I hate to use the word preach, but that's really what I would say is that I would talk to people about how they need to take time for themselves, and that you become a better studier, you become a better student, you become a better doctor if you do take the time for yourself. And I would say I become a better father if I take that time for myself. Because it's the kind of thing that if you're able to care for yourself, then you're much better able to care for other people. So I think that that's one of those things that, you say to a student, hey, I need you to go and meet with, a mental health professional for an hour every single week. And they're like, I can't afford to do that. There's no way.
Mm.
And you say, but you got to understand that if you're able to do this, it's going to make you so much more effective at everything else that you do in your life, that you will gain many, many more hours than that 1 hour that you're spending. And I think that that's something that's really hard for people to accept. And I would try and get students to understand this and say, look, why don't you take some time? Why don't you make sure that you have time for exercise every day? Why don't you make sure that you have time for oh, I don't have time to do that. I just can't. I just can't. And until you actually do it yourself, it's the kind of thing that you don't realize that it's possible. I was working with a resident 2 nights ago, and she was talking about how she wanted to sign up for a bunch of patients at the same time. Like she wanted to sign up for 6 patients immediately. And I was like, look, that doesn't make any sense because if you do that, then that means that the person that's number 6 is going to be waiting for an hour and a half to see you. As opposed to if you sign up for one and then you finish your chart and you sign up for the next and you finish your chart, you're going to be done with all your charts. All your patients are going to be taken care of in pretty much the exact same amount of time. And she's like, no, that's not true. I'm not going to see any patients. It's going to be like, I'm going to see like 5 patients total in a shift. And at the end of the shift, with me forcing her to do it this way, she ended up seeing more patients than she normally does. And that's the kind of thing that, until you prove to someone that taking time for yourself is going to make a difference and going to make you better at everything else, they're not going to believe you.
This is very true. I Very true. Yeah, just looking back at my own experience, what I was saying, medical school seemed easy once I finally got help. It's like
That's
what I
right.
was trudging through before was disaster, and I didn't even know it.
I 100% agree with you, Rachel. No
Yeah.
question.
I'm curious. I had a thought and I just lost it. I guess what I was going to talk about is, it sounds like you were able to get help before your career became a disaster, and I was able to get help before medical school became a disaster. But for some people, that's not the case, and they find themselves struggling, and things have completely fallen apart. And have you worked with people in that experience? And how do people, any recommendations or advice on how to navigate that?
Yeah, so I also was co-director for the Office of Professional Excellence, which meant I interacted with misbehaving physicians is the easiest way to phrase it. And then obviously with a lot of students that had difficulty. What I would say first of all is that you would be surprised at the number of resources that are available. And so, if your world is falling apart, go to someone that's in a position of power and ask them how they can help. And sometimes admitting the problems that you have is the first step to addressing some of those problems. So, I've had a number of students that had difficulties around drug or alcohol problems, and those students admitting that they have a problem was the first step to actually getting them the help that they needed. There are a bunch of programs that exist, like the Colorado Physician Health Program is phenomenal, and they do an amazing job of helping people out. And there are protections that are in place that help you from that perspective. And so, one of the things that we would have for students that were struggling is the first thing we would talk about is we would talk about depression, we would talk about drug and alcohol problems, and we talk about the different avenues that are available. And sometimes that means taking a pause in whatever it is that you're doing. And that's not the worst thing in the world. There are a lot of resources that are out there to help you get through those times. But sometimes taking a pause is what you really need to focus on yourself.
Well, and that brings up an important point is I think a lot of people are afraid of the impact it will have on their ability to maintain their medical licensure. And we were talking before this podcast began, there are many states now that no longer ask about a history of or current mental illness on your licensure application. Not all states, so it would be good to find out um, what your state licensure requirements are. But in many states, that's not even asked about. And in states where it is asked about, there often are what are called peer support systems. CPHP, Colorado Physician Health Program, is one of those systems where you can self-refer. And if you've self-referred, you are allowed to check no on the application if that is a question that's asked. Now, unfortunately, it is different state by state. And that's something where we still need to make a lot of progress because that is a significant barrier for some physicians in some states.
It's interesting that you bring that up. I think my brother-in-law is a pilot, and he and I were talking about this at one point in time in the distant past. And if you're a pilot and you're on antidepressants, then it's automatically a huge red flag for any company that's considering hiring you because they're worried that you're going to crash their plane. Whereas what they really should be worried about are the people that are not taking medication.
Mm-hmm.
That's really the people that they should be most concerned about.
Yes, exactly.
It's just this outdated rules that exist that we actually, as a society, right, we make it's just illogical. It's illogical. There's some stereotypes, and I really dislike stereotypes as a Russian woman.
Well, and you mentioned, Jeff, that reach out to someone in power. And I think that that's difficult because sometimes the last thing you feel like doing when you're struggling is reaching out to someone in power. And so maybe we could talk a little bit about what sorts of people in positions of power. And so you mentioned Office of, I think now we call it Office of Faculty Relations, which was Office of Professional Excellence. Anyway, professionalism office of some sort is often a good resource. If you have a counseling center or a faculty health center or whatnot. Faculty affairs would often be someone good to reach out to. Jeff, who
Student
do you
affairs if
recommend?
you're a student. Yeah, definitely. I think that there are a lot of people. I think that if you're a faculty member and you don't know who to go to, your chair should know who they can approach. And so going to your chair is really, really hard to admit that you're struggling to somebody that, to be honest, has a huge impact on your career. But I think that it's crucial for you to take that step. And I would say the other component is that having peers who are willing to help you navigate that is also crucial. I can't tell you the number of students who came in that said, I'm worried about this other person, and having that friend that's willing to say, hey, this person needs some help. Can you help me get them on the right track? I think is crucial.
I just want to jump in and say that I'm inspired by both of you so much because it starts with the leader, and you don't need to have like an official title. Someone like Rachel, that she is so brave and she normalizing it, so then others can come to her and ask her questions, and just creating that culture that we can talk about it. Like it makes such a huge difference. So and how lucky are the students that work with you, Jeff, and your colleagues. So it's really inspiring. It's sort of like this the next level thinking.
Well, thank you. I appreciate it. And honestly, I just think that it's the kind of thing that everybody should do.
Yeah.
I think that as more people like Rachel and I are open about our struggles and our difficulties, more people are going to fall into that category, and more people are going to hopefully get rid of that stigma that's associated with mental illness.
Yeah, and I have the benefit of treating a lot of faculty members, and so I know I'm not alone. I treat some people who are super high functioning and also struggling a lot. And I also get referrals from chairs across the board. So if you would not be the first person reaching out to your chair, I guarantee you they have had other people reach out that they've referred to connect with mental health issues or mental health issues. See, there I go again. Depression or psychiatric illness. Can't help
Uh,
it. Well, anything else, Jeff, that you would want to share with our audience? I guess well, maybe before we go there, we haven't really talked about other things people can do to get help. So let's say people don't want to reach out within their institution. What sort of resources would you recommend if that just feels too overwhelming?
Yeah, I think, there's resources that are outside of everyone's institution also. And from mental health helplines to suicide prevention helplines to contacting your insurance company and asking them who it is that you can go see. I mean, there are lots of alternatives that are available. And I think it also depends on where it is that you are. So, for example, for a large number of schools, they have things that are set up so that within the university system, there are opportunities that exist. I know that my local library actually has a group that meets to talk about depression, which I think is that idea of sourcing your community and however it is that you can to get help. But my hope would be that regardless of what you do, that you do some sort of reach out to get the help that you need, because I think getting on that pathway is so crucial. And like you said, Rachel, it makes your life so much better. in so many different aspects. You talked about your struggles during medical school and how much easier it was once you were being treated. And I think that is so true that once you get help, you do so much better.
Yeah. And also, if you don't do so much better right away, don't give up, because not everybody gets better right away. Sometimes it takes some trial and error, but just because you don't get better right away doesn't mean you can't be helped.
Yeah, one of my probably closest people that person that I'm closest to has been on 6 different medications and is still searching for one that's going to work well. And I think that sometimes happens. There are people that have treatment-resistant depression, and there are always other alternatives that are out there in terms of trying to find something else that works. And it's just getting with the right psychiatrist, getting with the right professional in terms of trying to treat the symptoms that you have.
Yeah, and I will say I have one physician patient who's open and openly shares his experience who needed deep brain stimulation. I have other faculty members who need ECT, and I even have faculty who are getting ongoing ECT every few weeks as maintenance and able to practice very well. So, very different levels of severity, and people can do well.
Agreed. 100% agree.
And if I may, I am in the presence of such experts. And as a nonprofit professional, I feel so passionate about speaking up about burnout, about depression in the nonprofit field, because you're supposed to just always be happy. You're supposed to always accommodate everyone's requests and be available at all times by text, by email, by phone. And it catches up with you. So a few years ago, I put together, it was my personal project, burnout prevention toolkit. And I would be so curious if Rachel can take a look. I'm very nervous to share that, but maybe you can take a look. If there's a little bit of value, like I'll be happy to share it with our listeners.
Yeah, happy to. And we'll put links to a bunch of different resources in the description of this podcast. So yeah, any final words, Dr. Druck?
I just want to thank you for having me on and to some extent giving me a platform that I can share the same thing that I know that you share on a daily basis, Rachel. And again, I guess I would just appeal to anyone out there that is struggling with any sort of mental illness that they take the steps needed to get treated. Well, thank you again for having me on.
All right. Well, thank you so much. It's been a pleasure.
Every moment matters. Every life matters. And you have the power to give the most precious gift of all. This episode of Transplant Talks is made possible by the incredible people who choose to give the ultimate gift, life. Through the miracle of living kidney and liver donations, they're changing the world, one transplant at a time. Visit AmericanTransplantFoundation.org to learn more about the living donation process and how you can make a difference.